All right, welcome. So I am going to address some of these questions written by our medical students as a practice for the NBME Shelf Exam and also later on USMLE. And I thought it will be good to go through these questions together and look at how they have been written, what options they're giving, and what answers are for those questions. So let's look at question number one. So it's a 77-year-old male who presented to the hospital after an apparent behavioral disturbance with his grandson. So 77-year-old, a male in behavioral disturbance. Patient claimed he was seeing lights flying around his grandson and became violent. Patient was started on carbidopa-levodopa 9 months ago due to help with bradykinesia, but state he has not noticed improvement of symptoms of his medication. So an apparent diagnosis of Parkinsonism started on carbidopa-levodopa 9 months ago, and now he's presenting with lights flying and becoming violent. He has a family history of Huntington's disease, and his grandmother died at age 62. Mother died at age 58, and sister died at 52 from complication of Huntington's disease. Now, this is interesting. So it keeps flying on its own. So let me try to go back. So this is interesting. So Huntington's disease is typically not seen in families at this old age. Huntington's disease typically starts in the 20s, late 20s, early 30s in most people. But late Huntington's is possible. Huntington's disease is a trinucleotide repeat disorder, so CAG. And the one of the features of trinucleotide repeat disorder is that the age of onset is dependent on the length of the repeat. So in Huntington's disease, for example, anything below 27 repeats of CAG at the end of the gene is normal, and above 34, 2 or 34 is considered abnormal. But longer the repeat, so if you have 40 versus 50 versus 60 versus 70, the younger the onset. And that's typical for all trinucleotide repeat disorders where there are three nucleotides being repeating. Now, this late age of onsets in the family, it will be suggestive of a very low burden of repeat. So somewhere around 40 or so, if I have to guess, or even a little less than that, because if you're above 40, typically the age of onset is in late 20s or early 30s, and if above 60, the age of onset is typically before age 18. Now, another interesting thing being pointed out here in Huntington's disease is that the inheritance is maternal, that is coming from mother and mother's mother and mother's sister. Now, another phenomena of trinucleotide repeat disorders is that the what we call anticipation, which is that the trinucleotide repeat length can increase sometimes, occasionally. It's not very common, it's very rare, but does happen when it's being gene is being transferred from parent to the child, which is basically when sperm or an oocyte or zygote is being formed. During that process of shuffling of the genes, the trinucleotide repeat length can expand. So even if the parent had a low repeat length, it may be a much higher in the child. However, the anticipation, for some reason, is classically seen either from mother or from father, and is actually very particular for each of the diseases. So, in Huntington's disease, for example, anticipation is almost always seen from father, and I don't believe of any case where anticipation has been reported from mother, meaning that the repeat length remains very stable when the repeat is coming from mother, which means that it should also be a late age of onset. And in this guy, the onset is close to 77-year-old of age, which is really late. I think that I have seen a patient where I diagnosed him in Huntington in 78 years of age, and he had symptoms for a few years. I'm not sure now, maybe 3 or 5 years, and the repeat length was 37. Very, very low repeat length. And usually, these families, with this late age of onset, sometimes don't even know that they have Huntington's running in the family. Here, they do know. In this case, that has been written. And it's a little unusual that parents are having it in their 50s, but the child or son is having it at 77 years of age. But real life is unusual like that. Upon examination, patient has prominent dementia and bradykinesia. Now, this will be a little unusual because prominent dementia means that it has been going on for a while, but the patient just got diagnosed 9 months ago. But people sometimes don't seek care, so that is possible. And bradykinesia, which is slowness, typically we associate with Parkinson's disease can be seen in Huntington's disease. So that is completely acceptable here. There was no chorea, ethitosis, tremor, myoclonus, or focal neurological deficit, and gait was normal. So, of course, chorea may or may not be present in Huntington's disease. However, typically later onset of Huntington's classically has chorea, and the younger onset of Huntington's typically don't have chorea, and they may have dystonia or myoclonus or other features. And now the question is, what is most likely lab finding? So they're asking you to challenge the diagnosis. Whoever started carbidopa levodopa, patient clearly is levodopa sensitive, and because of the dopaminergic increase from levodopa, patient is starting to hallucinate and has no clear benefit. So the question writer is telling you that there is no dopamine responsive bradykinesia, and the question will be, do you think this is Huntington's disease or not? And I think in NBME and in questions, usually we try to make things very obvious, and we don't try to mislead people or cheat people. So the answer should be the pathology of Huntington's disease. Now, what of these pathology is a Huntington's disease pathology? So amyloid plaques and neurofibrillary tangles, or it may be that they're trying to really give you a curveball and say this is not Huntington's disease and this is something else. Now that will be a huge curveball and typically not done in USMLE or NBME, where they give you such a strong family history of Huntington's and then tell you that, oh, patient is not actually Huntington's. So that will be very unusual. And it's not autosomal linked disorder, meaning that it cannot be that the mother cannot transfer it to the son. So that will not be a good enough justification in this writing of a scenario to say that this is not Huntington's disease. So patient has amyloid plaques and neurofibrillary tangles. So we know this is a pathology that we have been associated with Alzheimer's disease or Alzheimer's dementia, which he probably does not have, although bradykinesia can be seen in Alzheimer's. Hallucinations can be seen in Alzheimer's, but the pace will be very rapid. And age is appropriate. 77 can be seen in Alzheimer's. However, he has deteriorated with dementia and bradykinesia within months and or less than a year or two, and this will be very unusual for Alzheimer's. Now, intracellular aggregations of alpha-synuclein. Now, that is classical pathology for Lewy body disease, which is typically Parkinson's disease. However, another feature here will be Lewy body dementia. So patients who have predominantly cortical Lewy body involvement and not a substantia nigra involvement, they have presentation which is predominantly dementia presentation, although it has some Parkinsonism, and which could be this case. These patients are dopaminergic sensitive. Their hallucination get worse with dopamine. So if you take out the whole Huntington story out of this scenario, then this should be Lewy body disease or Lewy body dementia, where the patient has bradykinesia, Parkinsonism, but Parkinsonism didn't respond to low dose levodopa, and now he actually is hallucinating. You could add some other things to make it very definite Lewy body dementia, and which will be the classic triad of Lewy body dementia, which is rapid progressive dementia, hallucination. So two things are present. And the third thing will be fluctuating cognition. So often there is sundowning, but doesn't have to be. But some days they're worse than others. Some time of the days they're worse than the others. And so sometimes they're more lucid, more clear, and other times they're more confused. And in addition to dementia, they have this confusion. So encephalopathy or disorientation or confusion, which is a little different than dementia. Dementia is typically just slow cognitive deficit that is always present, not, confusion is something that comes and goes. And that will be a classic hallmark of a Lewy body disease, which is not present in this stem, which, I would have done it if I was really trying to convince someone of Lewy body dementia. And I would remove the Huntington's disease, by the way. Dopaminergic neuron degeneration substantia nigra is the classic Parkinson's disease. So now if they're giving B and C together, that means that B really they're trying to give you for Lewy body disease. Now, typically, again, this is something that I would not have done in writing options. So two options which are similar. So intracellular aggregation of mainly alpha-synuclein is Parkinson's disease. Dopaminergic neuron degeneration substantia nigra is Parkinson's disease. So giving two answers that are the same is confusing the person who is writing, who's answering this question, and that is a big no-no. You do not give confusion to someone. You really try to figure out if they know, check their knowledge, and not really just trick them into giving you wrong answers. And that's not your job. So again, this is probably not have been done. And then D is abnormal number of CAG repeats, which is the Huntington's disease. And to me, that will be the right answer here, because if it quacks like a duck, if it walks like a duck, then it is a duck. So if there is 3 family members with Huntington's disease and the patient is having cognitive decline, having Parkinsonism, late age of onset, everything fits with possibility of Huntington's disease, and then you cannot rule it out. So to me, the right answer will be abnormal number of CAG repeats. And then presence of 14-33 protein in CSF is basically a diagnostic for CJD, Creutzfeldt-Jakob disease, which could be concerning in someone at any age who has a rapid progressive dementia. And Parkinsonism can be seen, is not exclusive. But again, the 9 months of progression may not be enough, although in some form of CJD, such as variant CJD or sporadic CJD, which is genetically inherited, there may be a slow progression over 18 months and not classic 3 to 6 months progression that we see with CJD that you get by eating an animal meat that have prion proteins or prion disorder. But still, there is not many things here that makes you think of prion disorder. There is no myoclonus, there is no rapid decline, patient is not bed bound, there is no hunting or animal meat eating, or and so on and so forth. So there's really nothing here that is pointing you, suggesting you that this might be a prion disorder. So let's see what the writers pick up the answer for. And they picked up the intracellular aggregation of mainly alpha-synuclein, Lewy body dementia. And as I've explained, that this would not be the best stem for Lewy body dementia. I would have to rule out, I would have to get the Huntington's out of the stem, and I would have to add the fluctuating cognition as the third pillar or third triad of the diagnosis of Lewy body dementia. And then I will take out the C because you cannot have two very similar or similar related answers into the questions to confuse, and add some other dementia. You can have Pick's disease, ballooning neurons, or something like that, and there are many other types of dementias that you can throw in there in the stem to make it 5 options.